from a practical perspective, starting off with a metabolically friendly agent, they often might not have the antihistamine receptor, and sometimes can have an activating effect. Is that something that you found common in when you're starting patients on, say, Lurasidone or Brexpiprazole? And do you combat it with an augmentation strategy?
Actually, I don't see it very much at all. Once in a while, it's true that we have some people, I would say more with the Brexpiprazole than with Lurasidone, who would get a little bit of an activation, in the same way that people who are taking an antidepressant sometimes get a bit activated at the beginning, some more than others. For example, bupropion, or more than an SSRI. But I would say it's a small minority of patients. And I think the clinician perception is more that they are missing that sedation that they are so used to seeing with risperidone and olanzapine, rather than there's an activation that's happening. They're saying, well, what's wrong? This patient isn't slowing down enough. So I think that's much more the real issue that's going on. Now, if one does get if one has a patient who is a little bit more sensitive to this activation effect, probably it means the dose should be a bit lower. And that patient might respond much better to a lower dose. And interestingly, we see this activation with the older medicines like olanzapine and risperidone. I'm sure many clinicians that are going to be listening to this have had the experience of a patient who's taking olanzapine or risperidone at bedtime and who tosses and turns before going to sleep. And for me, this is a bedtime akathisia. And most clinicians will not look at it as such, but the patients will describe it very well as tossing and turning before falling asleep finally. And sometimes clinicians will increase the dose of the medicine to make it. So it's not just a phenomenon that we see with some of the newer medications. The older medicines, depending on the dosing, can also produce a little bit of an activation, which we would call akathisia. Now, reducing the dose is probably a good way to start, but there are going to be people, I think you are correct in saying this, that will require some sedation, some bedtime sedation, or usually bedtime sedation. And there, I think it's the clinician's choice. What's the thing that you're most comfortable with and the least horrible thing to give the patient? Would it be something like a benzodiazepine? Would it be something like a pregabalin? Would it be something like a more sedative antidepressant like a trazodone or a small dose of mirtazapine? So there are good pros and cons with those choices.